Yet that 2% difference to her is life-changing because she couldn't tolerate the estrogen blocker.
Nearly 40% of women didn't feel supported when they talked about intimate dryness to their doctors.
And although I don't like to bring sexism into it.
Welcome to End the Dry Spell, a conversation with leading women's health experts about intimate dryness. I'm Fiona Toomey, the founder of the skincare and wellness brand NAYDAYA. And we're calling on the nation to end the dry spell of awareness and put an end to the stigma around intimate dryness. And we're here to bring matters of moisture into the mainstream. And we really think by normalising discussions about intimate dryness, we believe we can increase its visibility on the women's health agenda. We surveyed over 2,000 women and we got some really interesting results. 83% of women said they experienced intimate dryness at some point in their lives. And nearly 70% of you who suffered from intimate dryness said it affected their sexual relationships. So today we're chatting to Anne Henderson. So welcome, Anne. And just so our viewers know who you are, Anne is a consultant gynaecologist and a British Menopause Society Advanced Specialist, and she has over 30 years experience. So she's a wealth of information. So we are so excited to have you here today. Anne has extensive knowledge and expertise in the field of menopause. Anne is also known as the gynae expert and is the owner of the Amara Clinic, which specialises in menopause care. So welcome, Anne. Thank you so much for coming. So please introduce ourselves to our viewers.
Hi, thank you so much for asking me, Fiona. It's lovely to speak to you in this intimate setting. I mean, obviously, we've been working together now on screen and in person for a long time, about 18 months probably, since we first linked companies.
Yes, and so tell me, how did you get into your profession, or where did you start? How did you kind of start specialising in menopause?
So I obviously trained as a gynaecologist, and many years before I set up the Amara, I was a much more conventional consultant. I was a consultant obstetrician and gynaecologist. Nowadays, I just focus on gynecology, but for the majority of my career, I did both. So I've had huge experience in the trials and tribulations of pregnancy, childbirth, and aftercare. And obviously, some of the products that you produce are used for pregnancy as well. So I appreciate it's not exclusively menopause. So my training was always in surgery, gynecology, as well as obstetrics. But my postgraduate research when I was a junior doctor was in menopause. So it was in menopause, perimenopause, PMS, and postnatal depression. And that sounds a bit of a mixed bag, but I was very fortunate that I trained with Professor John Studd, who sadly has now passed away, but he was really instrumental in raising awareness about the role of hormones and well-being. And he was decades ahead of his time, because a lot of the practice that we're seeing nowadays in the 2020s was around in the 90s when I did my research. We were using transdermal patches and transdermal gel to treat menopausal symptoms and also to treat PMS and postnatal depression. And there's a huge link and synergy between these conditions throughout a woman's life. So although they sound as if they're not linked, actually, if you look at the hormonal basis of mental well-being, estrogen is the key throughout. So that really set the tone for my career. And again, you often don't realise till many years later how fortunate you were, because it's very difficult for somebody training nowadays to get that level of in-depth knowledge. I trained with him for 3.5 years, and the expertise that I learned, I'm still using now. And throughout the rest of my career, I have focused, obviously I've done training as one would do to reach consultant level, but I've run menopause clinics even from when I was a junior registrar right all the way up through in the NHS and now privately. So it's not something that I've just jumped. There's always a worry that somebody's just jumped on the bandwagon. And for me, that's a big worry. I think there are a lot of people jumping on the bandwagon. You probably see that in your specialty as well. But I think menopause is such a trendy and sort of focal subject at the moment that I think there are people who are getting into it without proper training and expertise, and that's a huge worry. I'm somebody who's been doing it for decades, and I've been through it from thick and thin, difficult times and easy times, and it's very important to have that expertise. But yeah, I'm still here. 30 plus years later.
How do women navigate that, though? How do they know that, I don't know, people are not just jumping on the bandwagon or maybe don't have the training? Because it's a difficult landscape, I think, for us to navigate, because some GPs don't have the specialist training.
Absolutely. It's a minefield, and obviously there's the phrase caveat emptor when you're buying things. I would say to patients, buyer beware. And actually the biography that I have that we send out to patients isn't just talking about my clinic. So potential clinic patients get a summary of our, obviously, terms and conditions, but in the information I send out to them, I'm very clear that you need to do your homework, and you mustn't just jump on the consultant who has the shortest waiting list or the flashiest website or the glossiest promotion, because that might just be a very superficial facade, and if you scratch deep, they're not properly trained. I would say patients should be looking for somebody who ideally has the advanced British Menopause Society training that you've just mentioned. I have. That means they're registered with the BMS. They're not just a member, but they're an advanced member. And to get the advanced membership, you have to show evidence of a much higher level of training, expertise, scientific background, publications. And you have to have an ongoing caseload, which is audited to show that you're not really just doing menopause as a sideline. You're not just seeing one or two patients a week. You've got a serious caseload. And there is a menopause map, which is called the British Menopause Society Menopause Map, which all patients can access. You don't have to be a member. If you just Google it, it will come up. And you can put your postcode in, and the site will give you all the accredited clinics across the UK, both private and NHS. It's updated regularly, so it's a great source of information. And I would say any woman who really, I'm not saying everybody has to come privately, but if you want to get really in-depth quality information from a specialist, that's the best site to use. And it doesn't include anybody who's dabbling in menopause who hasn't got the proper credentials. So it's a very good source of information.
So, I have a technical question for you. Mm-hmm. The vulva and the vagina are often confused. And I do think this goes back to education, because I did not know what a vulva was when I was a little girl and I was learning the anatomy. So, can you just tell us the differences and, yes, just the differences basically between both?
So it's not helped by the fact they both start with V, and they both can be quite difficult to pronounce and spell. So in many ways, it's easier to think about the external organs and the internal organs. So the vulva basically refers to any part, if you like, of the intimate female anatomy that's external. So it goes right up to the pubic bone, and it includes both labia, large and small, or in medical terms, major and minor. It includes the clitoris. It includes the urethral opening, which is the opening to the bladder, the vaginal opening to the vagina, and then the tissue that extends back to the back passage or the anus. So it's a huge area in terms of complexity. And, it's easy to understand why there's confusion, because it's, as you pointed out, it's not taught about in school. You don't learn about that in PHSE. GPs often don't explain to patients what's going on, and unless somebody's taken it upon themselves to learn, they're probably still in the dark. But if you think of the vulva as being exterior, and literally tailbone to pubic bone, that's a good guess. The vagina is internal. So the vagina is the passageway from the exterior, or the vulva, to the womb, or to the cervix, to be more precise. And the cervix is the entrance to the womb. So the vagina is largely invisible. You can't see it. You can see the entrance, but you can't see the vagina unless you're doing a gynae exam with a speculum. So what a patient or one of your clients would see would be the vulva. That's the exterior organs and area that they're aware of daily day.
It's a great explanation. I feel like, yeah, we all need to know that. And we've discussed in the past, but you've mentioned that often vulva problems and issues are misunderstood or misdiagnosed. What kind of things do you see as misunderstood or misdiagnosed sometimes?
So I think there's often just a general misunderstanding about what causes symptoms, whether it's pain, discomfort, itching, or irritation. Sometimes symptoms can transfer from other areas. So, for example, vaginal discharge might cause vulval symptoms because the discharge itself can cause external irritation. If you have a heavy, thick, irritant discharge, you might not be aware of vaginal problems, but the discharge might start to irritate the external vulval skin. So somebody might come along saying, I've got pain in the vulva, it's red, it's irritated, but actually the initial problem is nothing to do with the vulva, it's internal, which is why there's a close synergy between the two areas. And again, you can get referred pain. I mean, I've seen women who come with what they think is vulval pain, but they might have cystitis. And not all women with cystitis have bladder pain. They might actually have pain that seems to be deeper, and they experience it as pain on the perineum or vulva. Perineum is often used with vulva. They connect. One might use the same term. So it often pinpointing exactly what's going on can be difficult, and it's not necessarily as straightforward as it might be in other parts of the body.
So Anne, what causes intimate dryness, and are there different types of intimate dryness?
There can be different types of dryness throughout a woman's life, but the commonest unifying cause, if you like, is usually hormonal. So I would say it's very rare that a woman would come to see a specialist with a healthy hormone makeup without any other problems such as infection or other issues and complain of vaginal dryness. There usually is a cause behind it, and in most cases that cause is a hormonal shift. And the commonest shift is a change in estrogen levels, and that's usually a drop in estrogen levels. And the two times that one sees that are postnatally and then peri and postmenopause. Postnatally, you might think, well, that's a weird time to have vaginal dryness. You've just had a baby, you've got secretions, you've got vaginal bleeding, you've got lots going on. But the one thing that happens after childbirth, which in many ways mirrors menopause, is you have a huge drop in estrogen levels. So during pregnancy, estrogen levels are very high because of the placenta and the hormone circulation. And the minute you deliver, hormone levels drop off a cliff edge. So there is definitely a mirroring between postnatal and menopause. And that's emphasized further if you are breastfeeding, because breastfeeding suppresses those estrogen levels even more. So many women who are breastfeeding end up in an almost pseudo-menopausal state, and that's one of the commonest symptoms that we hear about is baby brain or baby fog or brain fog after a baby. And that is very similar to menopausal brain fog. Vaginal dryness post-birth can be very similar. And again, women often find it very unusual because, they've given birth, there's been a lot of discharge initially and bleeding that can go on for a few weeks. Then often the dryness kicks in. So same happens in menopause, declining estrogen levels, and that affects the glands in the vagina and cervix that produce discharge and secretions. It's a simple connection. Estrogen promotes healthy discharge, healthy pH, which is very acidic, about 2.5, which in turn promotes vaginal health, lack of yeast, lack of unhealthy organisms, and that's what creates a healthy vaginal discharge.
So, is there a cure for intimate dryness? And what helps it? What makes it worse? What can women do?
There is a cure as such, so you can reintroduce moisture. And we'll come on to that in a minute, but it might help me talk about what makes it worse first, because that's very easy to do. I mean, if you avoid things that make it worse, that's fuss free. So the things that always make dryness worse are anything which will disrupt the natural pH, the microbiome, which is absolutely essential to maintain, and anything that affects the skin barrier. And those are things that would affect skin elsewhere. So aggressive cleansers, perfumes, moisturizers, shower gels, soaps, all of the things that could affect the skin barrier on your face or body, and they're much, much worse in the vulval area. And the culprits are things like alcohol, perfume, parabens, SLS, glycerol. These are all really unhelpful. Anything that will disrupt the acidity. So sadly, most washing agents are very alkaline. So they tend to strip the skin, they disrupt the acid pH, and they can create a very unhealthy environment. And the microbiome is essential. If you don't have a healthy microbiome, you could either have excessive discharge or inadequate discharge, because instead of the lactobacillus, which is the organism, it's like the super bug that you want, you end up with coliforms from the bowel, yeast, other unhelpful organisms, and it allows the nasty bugs, if you like, to thrive. So you want to have a healthy skin barrier, and you want to have a pH that's around 2.5 to 3, so it's very acidic, much more acidic than other areas in the body, and a healthy microbiome. And that's a good starting point. Try and avoid anything that might disrupt those key points. In terms of cure, you're really looking at replenishing moisture, superficially, if you like, or replenishing the root cause of the lack of moisture, which is going down the hormonal route. So if your main issue is lack of estrogen, replenishing estrogen, either locally with pessary or a cream, or systemically with HRT, will do the job. Topping that up with local moisturizers and lubricants such as your NAYDAYA Victory Oil. That's the recommendation that I would make.
So when you talk about the cure and the different types, do you have a different cure for people at different stages? Because I had my first bout of intimate dryness after I had a baby, when I was breastfeeding, but I definitely wasn't offered kind of estrogen or anything at that point. And then now I'm being offered kind of different options. But is there different cures at different stages?
Well, I think the most important thing is for the person, the woman, to be educated about what's going on and give her advice that's appropriate to that stage in her life. And you're quite right. You wouldn't be recommending that somebody who's just had a baby, who's postnatal, who's breastfeeding, goes on to HRT. I mean, unless there was evidence that they'd hit premature menopause, that would be overkill. I think what they need to be given is advice so that they can understand that this is a temporary phenomenon, and that it's a biological phenomenon, that they're not going to spend the next 40 years with vaginal dryness and symptoms, that this is very much related to having given birth and breastfeeding. Biologically, if you go back to our ancestors, you might say, well, why on earth would somebody who's given birth, been through all that trauma and she's breastfeeding, have vaginal dryness? But one could argue that it's a way of stopping her getting pregnant again quickly. Obviously, breastfeeding does that as well because she's not like to be ovulating. But you can see there's usually a biological reason why things happen. even if in evolutionary terms, it doesn't necessarily work with life nowadays. So for somebody in that category, you'd be recommending symptomatic control. Products like the Victory oil, for example, or similar products which will be very neutral. There's no risk of irritation in that area. There's no risk of cross referral or cross contamination with breastfeeding or with anything else you might be doing. So I think keeping it very simple in that sort of situation is the proper approach. Whereas if somebody's got vaginal dryness because they've hit perimenopause or menopause, you can educate them to understand that it is a permanent situation. It's a very different situation than somebody who's just given birth. So if somebody's in their 40s, early 50s, they're more likely to want to take proper action because they know that this is something they'll have with them probably for the rest of their lives. So it has a much greater impact on life quality. And that's when you have a different discussion about, are you just looking for more of an easy, straightforward approach, or do you want to actually tackle the core, which would involve hormones?
So I think it's important that we just talk about postmenopause, because we think menopause is a number of years, and then once it's done, we're finished. What happens to our bodies postmenopause?
So that's a very good point to bring up, because there is this incorrect assumption that menopause just lasts 15, 18 months, 2 years, and then you're back to normal. And I've heard so many patients say they've been told, oh, man up, get on with it. It's a natural part of life. It'll be over soon. And actually, that's biologically, that's misinformation. Because once estrogen levels drop, they drop forever. They don't bounce back. They do after a baby, of course they do, but they don't when you hit menopause. And once you're postmenopausal, your hormone levels will be virtually unrecordable for the rest of your life unless you go on to HRT. So it's important that a woman understands that. They don't bounce back after a few years. That's it. And there's this misapprehension that the symptoms are acute for a year or two, maybe a few years, and then symptoms gradually resolve. Now, that's true to some extent for symptoms such as flushes and sweats. So let's take flushes and sweats, which occur in about 90% of women. So it's true to say that they are often worst in the run-up to menopause and for the first year or two after. And for most women, they do subside. But unfortunately, many other symptoms, particularly symptoms related to atrophy, so I'm talking there about lack of collagen in the skin, nails, hair, bones, skeleton in general, and the vaginal tissues. So that atrophy that you get caused by a lack of collagen from declining estrogen does not recover. Sadly, the brutal fact is that it's a one-way street. Collagen only goes downhill after 40. And it's not going to bounce back. So when you're 55, 60, 65, estrogen levels are depleted, collagen is depleted. And that is the root cause of many of the problems that we see. It's not great news when you hit menopause and beyond, but I think, again, it's better that women have that clear understanding about biology. They don't want to be fobbed off by somebody going, get on with it, you'll be fine in a few years. The likelihood is that won't be the case.
Yep. And if we talk about HRT for a second, so does it fix everything, and can you stay on it forever, or do you find people go on it during the years maybe when they're experiencing a lot of kind of ups and downs? Do they come off it? Like, what do people do? Can you stay on it forever?
You certainly can. Stay on it forever. I wouldn't say that's for everybody, but again, it's a dialogue to be had. What works for one woman wouldn't necessarily work for her sister or her best friend. But it's definitely true that there's an increasing trend amongst patients and indeed amongst their specialists to recommend long-term treatment. And by that, I mean 10 years, potentially more. And many women who feel they have a great quality of life, they don't have side effects, they're not bleeding, they generally feel great. There's a drive to carry on. because their argument would be, well, I feel so well, I've got a great quality of life, why would I want to come off? And you have to have that dialogue about risks and benefits in each individual case. So the bottom line is it's perfectly safe for women to remain on HRT long term as long as they're being monitored and they're in contact with a specialist, somebody who knows what they're doing and somebody who's properly educated in long-term HRT.
So does HRT fix everything, and where may it not be appropriate for some women?
So HRT, if it's done properly, and that's a big caveat, will fix pretty much everything. I would like to think that our patients, after about 4 to 6 months, if you said to them, what's your symptom control? Give me a percentage. 0 is baseline, 100% is feeling great. Where are you? I'd like to think that most of them would be 80 to 90% on that journey. So they're pretty much there. There's always going to be a few little niggles, usually minor issues. Sleep and brain fog, to be honest, are the commonest, and they're often linked. But pretty much everything else improves dramatically. And to be fair, in most women, sleep and brain fog also improve. So I think in terms of fixing everything, if HRT is done properly, it will. But sadly, we see many women nowadays, and we see them every day in my clinic, who are on HRT. So they've ticked the box, they've done the right thing, the GP's prescribed or the practice nurse has prescribed the HRT. And when you drill down and actually ask them how they're feeling mentally, physically and emotionally, they're not feeling great. So they're in this awful grey area that I describe between not having HRT at all and having HRT that's been optimised. And that in many ways is it's a sad position for the patient, but as a specialist, it's one that probably upsets me more professionally than somebody who's never been on treatment, because she's got nothing to compare it with. But the woman who's on HRT, who still doesn't feel great, and then looks at social media and she sees well-known media stars, I'm not going to name any names, but, people saying it's changed my life, it's given me back my va-va-voom, I feel like I did before. If you're someone looking in from the outside and you see that and you think, well, I don't feel like that, I feel pretty mediocre, it's awful, because the women then think, what have I done? Is it me, And usually it's not. It's the HRT, it's the combination or the dose or the absorption or just the general advice they've been given. So the good thing is that with some expertise, they can usually turn it around. But that is sadly a never increasing part of our workload, not something I would have seen a few years ago, but something I'm seeing now, because women are not being properly advised once they're on HRT. They're just given, here's your HRT, off you go. And sadly, that rarely works. And if it does, I would say it's probably by luck rather than judgment and skill. And, with GPs, they're often overwhelmed. And, the women just think, oh, I'm so lucky, my GP's given me HRT. So they think Christmas has come, but they don't realise that actually it's pointless having it unless it's the proper dose, the proper combination, and they're applying it, I mean, like the gel, I've had women popping gel on their shoulders and shoulder blades, and you think, well, you don't want estrogen going into your shoulder joint, it's not like it's Voltarol gel, what are you doing? And nobody's told them what to do. So I saw somebody the other day who was actually wearing patch, and her estrogen level was exactly the same as it was 6 months ago before she started HRT.
Okay. And
it was on her bum, and it never stuck properly. It kept coming off because it was in the wrong place. And she had quite a slightly different skin texture, so the patch wasn't sticking, so the estrogen wasn't getting into her system. It was just ridiculous. She'd just been wasting her time for 6 months.
Yeah.
So it happens.
Yeah. So we get a lot of women who can't or choose not to use HRT. So why might some women not be able to use it or not choose not to use it?
So I'm not. Obviously, I'm an advocate of HRT, but I don't have tunnel vision. And everybody who comes to see us at the Amara does not go away with an HRT prescription. If it's appropriate for them, they will. But if it isn't, through choice or medical reasons, then there are many other things that women can do. And one of my passions is looking at complementary, particularly herbal medicine. And in my natural menopause book, which came out with Dorling Kindersley a few years ago, we have 5 pillars of menopause, which obviously include HRT, but also include herbal medicine, fitness, nutrition, and general well-being, mental well-being, of course. And I have worked with several very experienced herbalists for many years, one in particular for 25 years nearly now. So long before herbal medicine became popular, I had a particular link because I could see that it made sense. It makes sense from a pharmacological basis. It's not all smoke and mirrors. There's a huge amount of science and history behind it if it's done properly. And I would always welcome women going down that route if they were wary or perhaps didn't want to embark on HRT. You know, I think if herbal medicine is done properly by an expert using phytoestrogens and adaptogens, herbs such as black cohosh, red clover, ashwagandha, turmeric, Siberian ginseng, they all have their different properties, but if they're blended professionally, they can have an amazing impact. Incredibly safe, they're non-habit forming, and they can be titrated to suit individual patients. So it's not a one-size-fits-all. I'm not necessarily advocating that women just pop off to the local health food store and pick things off the shelf. That might work. And there are some great ready-made products that are available. But again, I think you've got to do your research. You've got to know what you're taking, why you're taking it, and if in doubt, get expert advice. And that might be the best option for some women who perhaps are advised not to have HRT, although it's true to say that as time goes on, that group of women is getting much smaller. This week alone, I mean, we're filming this in the middle of the week. This week alone, just to give you a feel for women who are coming forward, in the last few days, I've seen 6 patients, all of whom have been diagnosed with breast cancer of different types, but predominantly estrogen receptor positive, which is the hormone sensitive type of cancer. And each and every one of those women is going to stay on HRT. They might have come off it temporarily to have breast cancer treatment, but they've decided, they've looked at the risks, they've looked at the benefits, the recurrence rates, they've spoken to their oncologists and their surgeons and myself, and they're going to stay on HRT. Now, a few years ago, 5 years ago, perhaps 10 years ago, that conversation would not have even taken place. I would not be writing letters to oncologists saying, this is an option, this is what we've discussed, this is what I propose. And the oncologist wouldn't be saying, you know what, if you really feel your quality of life is unmanageable, it's fine, you know. So there's now a dialogue opening up, which is long overdue. And I keep saying to patients, none of us should be playing God. It's not for the oncologist to say to the patient, you must take this chemotherapy, this hormone blocker. It's not for me to say, oh, you must have HRT. What we should be doing is coming from our point of strength, our education and training. I'm not an oncology specialist. Oncologists are certainly not hormone specialists. And I know that from speaking to my colleagues. I think we do what we do well. We collaborate. We put the information in front of the patient, you know, in a way she can understand. I mean, we're not expecting somebody to go and read endless documents and so on. And the patient then thinks, you know, if I do X, this is what will happen. And if I do Y, this is what will happen. She makes the choice. That's actually enshrined in the law. And a few years ago, a judgment was passed called the Montgomery judgment, which was, I think, a game changer in terms of the way that doctors and healthcare practitioners respond to patients. And it was based on a tragic obstetric case in Scotland. Montgomery was a Scottish woman who went through the Scottish courts, the English courts, the European courts, and her case is now enshrined in law. And it was all about how we give information to patients, and it has to be in a manageable, non-judgmental form. One of the problems with the Montgomery case was the obstetrician put her views into the patient's arena and almost insisted that the patient follow the decision that the consultant had made rather than let the patient make her choice. And that's what I still see happening in some cases. Sadly, some oncologists still have that very paternalistic view. I think that needs to go. I think everybody needs to have an open dialogue. The patient makes the choice in the end. And I said to a patient yesterday, fortunately, her risk of breast cancer recurrence were very low. They were about 2 to 3%. If she didn't have estrogen blockers, they were going to go up to 4%. So her oncologist has said to her, your risk is going to double, which it was true. It went from 2 to 4%. But if you look at the basic figures, most women would say a recurrence risk of 4% is tiny. So she's got a 96% risk it's not going to recur if she doesn't take estrogen blockers. And yet that 2% difference to her is life-changing because she couldn't tolerate the estrogen blockers. It wrecked her. She had to leave her job. Her marriage was on the rocks. Her kids were threatening to leave home. It was a bit of a storm for 2%. So who makes that call? It's not the oncologist, it's the patient. Yeah. And the patient said to me, if they turned around and said, it's 20% risk of recurrence, she said, I would have taken it because I could not cope with my quality of life for a week longer, never mind the rest of my life or the next 5 years. And the same applies to HRT. We've got to get that information in front of the patient and say, these are your options, you make the choice, and then we're here to support you. So there are, as I've said, going back to the question, there are virtually no cases now, I would say, where HRT is completely forbidden. There are cases where it needs to be done by an advanced specialist with lots of experience and training, but there are very few cases where even I would say, no, definitely not.
So are there any lifestyle factors that significantly affect intimate dryness?
Yes, there are. There are certain lifestyle factors, including the points that we discussed earlier. I think women who experience dryness often rush before they even go on to HRT. They're out shopping on the internet, they're going to Boots, and there are other pharmacies and chemists, so, all around, buying products, intimate washes, douches, moisturisers, lubricants. I've seen patients that I've done consultations with who literally will open their bathroom cabinet. When I ask them, what are you using? And they can't remember the name, they'll show me the bathroom cabinet, and it's almost like a pharmacy shop front. And sadly, there are very few products that I would recommend that fit the bill, that don't contain any of the irritants, the additives, the harsh agents that women should avoid. It's easy to be sucked in by a promise of comfort and lubrication without actually scratching below the surface and seeing what the products involve. So I think looking at what you apply to the skin and the vulval area is very important. The second point that I would look at is diet. I'm not fanatical about diet, but it's certainly true that there's evidence that diets that are high in sugar, particularly refined carbs and sugar, can promote blood sugar fluctuations, and in turn we know that that affects the vaginal microbiome, and it can lead to an increased risk of thrush and candida and local intimate infections. So I think the two things I would recommend are watch your diet, keep things in moderation, but be very careful about what you apply to the genital area. And that goes across the board for lubricants, moisturisers and agents to wash with as well.
And what about exercise? Like, if you have severe intimate dryness, can you exercise? Are there things you should avoid?
So exercise can cause irritation more from sweating rather than having an impact on the dryness. Sweating can cause local irritation. If there is dryness generally, then certain exercise, cycling, for example, and running more than others, where there is a repetitive action, there might be chafing or pressure. If there's dryness, then that can cause discomfort. It can even cause erosions and roughness, local bleeding, and that can be quite unpleasant. So the option there is to moisturise the area as best as possible.
So we surveyed over 2,000 women, and I'm just going to read you some of the stats and you can let me know your opinion. So over 80% of women said they had experienced intimate dryness at some point in their lives. So this is like all women at all stages, which I thought was really interesting. But this one was, so nearly 40% of women didn't feel supported when they talked about intimate dryness to their doctors. What do you think about that?
I'm not surprised, given the discussion we had earlier about some of the advice given regarding menopause in general. And you know, there's a lack of training and education across the board. So GPs are often on the back foot when it comes to advising women. So I would say to somebody who's starting off on this journey, I would pick your advisor carefully, and sometimes practice nurse might be more approachable than a GP, and many practice nurses nowadays have really quite significant levels of training in women's health. I think and they sometimes have a bit more time, their timetable's a bit less rushed, and they're usually female. And although I don't like to bring sexism into it, I think it's true to say that most women would rather have a chat with this sort of subject, dryness, intimate dryness, and speak to a female. Not invariably, but I think that's generally true, whether it's postnatal or menopausal. So I think pick your healthcare practitioner, make it sure it's somebody that you can relax with, that you can trust, that you feel comfortable talking with this area, because it can be quite embarrassing, it is quite sensitive, and I think if you feel that the other person isn't someone you can open up to, you're not going to have the sort of conversation that you need. And I would say be honest. I mean, don't try and beat about the bush and not be honest. Otherwise, the person can't really help you. And I think if you feel that they're perhaps out of their depth or they're not well equipped, then move on to speak to somebody else. I would say don't take no for an answer. You might need to have an examination, so do be prepared for that. If you've got dryness and irritation and perhaps other symptoms, perhaps, for example, discomfort with sex, then you probably do need to have an examination. So you have to be comfortable with the person who's going to do that. So I would go, if you like, forewarned. As they say, fail to plan, you plan to fail. And I think especially with things like this and anything else to do with menopause, it's good to have your backup plan and go with all your questions and what you want to get out of the conversation, so that hopefully it's successful.
Thank you so much for joining us today. I have learned so much, and I know our listeners will really appreciate this, because I feel like there's so much information out there, and I feel like it's a very digestible form they can listen to and get some amazing information. So thank you so much for joining me today, and thank you so much, Anne, and please check out our campaign End the Dry Spell on NAYDAYA.com.
Thank you.
We really hope you enjoyed this series of End the Dry Spell, and I really want to know if there's anyone else that you want us to talk to or any other conversations you want us to have. Please let us know.